This is Dr. Lori Gardner, and this lecture is on anemia for Nursing 517, Advanced Pharmacology at Nicholls State University. Anemias are extremely common in primary care practice, affecting an estimated 3 million Americans. According to the World Health Organization, they estimate that the prevalence of anemia worldwide is about 42.6% in children, 38.2% in pregnant women, and 29.4% in all women of reproductive age. Anemia is a sign of disease rather than a disease itself. Iron deficiency anemia is the most common type of anemia, with a prevalence of about 14% in children ages 1 to 2 and 9% in women ages 12 to 49. Anemia of chronic disease develops secondary to a chronic disease, such as cancer or long-term infection, and it's the second most common form of anemia. The third major form of anemia is sickle cell anemia, which affects 100,000 Americans, mainly African Americans. Pathophysiology that is common to all anemias is iron deficiency anemia, folic acid deficiency anemia, pernicious anemia, anemia of chronic disease, and sickle cell anemia. The objectives of this brief lecture is to discuss the pathophysiology common to all anemias, describe rational drug selection for specific types of anemia, and discuss the monitoring and patient education needs of patients with specific types of anemia. Again, this lecture is brief. It is only focusing on anemias. The underlying pathophysiology in all types of anemia is a decrease in the oxygen carrying capacity of the blood. The reasons for this decrease vary by type of anemia. You can look at figure 28.1 in your books, and that will depict the progression and manifestations of anemia. Anemias are classified by erythrocyte size and hemoglobin content. Size is referred to the terms microcytic, which is small, macrocytic, which is large, or normalcytic. Hemoglobin content is referred to by the terms hypochromic, which is a low hemoglobin, or normochromic iron deficiency. Iron deficiency anemia decreases oxygen carrying capacity because of the low hemoglobin concentration due to reduced red blood cell production or the lack of adequate iron intake, poor absorption of iron by the body, or lead poisoning. So iron deficiency anemia results from inadequate intake or acute or chronic blood loss, and it is treated with an iron replacement. Okay, let me go back. Make sure I told you guys everything you need on iron deficiency anemia. Okay, let me give you a little bit more information. Iron deficiency anemia may be caused by increased demand for iron during pregnancy, periods of growth in children, blood loss from menstruation, or chronic low volume of blood loss from the GI tract, or some type of malignancy like in cancer. Multiple myeloma, we see that quite often. Pathological iron loss occurs most often from GI bleeding. Gastric and duodenal ulcers, diverticular hemorrhoids, ulcerative colitis, and malignancies are common sources of bleeding. GI bleeding is such a common cause of iron deficiency anemia, or IDA, which I will refer to it as, that is recommended all men and postmenopausal women with IDA And all premenopausal women whose IDA cannot be explained by heavy menses should be evaluated for an occult GI bleed. So let's talk about folic acid deficiency anemia and pernicious anemia. Folate deficiency anemia, or FOA, is rare in developed countries, but certain groups are at risk for deficiency, including those with alcohol use disorder, because alcohol interferes with the folate absorption and metabolism. Patients with malabsorptive disorders and pregnant women usually are more affected. FOA decreases oxygen carrying capacity because of the low hemoglobin concentrations. Folic acid is necessary for normal maturation and functioning of red blood cells. Folic acid deficiency produces a macrocytic normochromic anemia within 3 months of the start of an inadequate diet because folate stores are rapidly depleted. Okay, let's move on to pernicious anemia. Pernicious anemia, or PA, also has a low hemoglobin concentration. PA is also associated with other autoimmune conditions, particularly those that affect the endocrine system, such as Hashimoto's thyroiditis, type 1 diabetes, Addison's disease, celiac disease, and Graves' disease. PA produces a macrocytic normochromic anemia that develops slowly, often over years, and it's frequently severe before it's even diagnosed. They may have vague early symptoms like infections, mood swings. They may have GI, cardiac, or kidney problems that are often ignored. The classic symptoms of anemia are not seen until the hemoglobin approaches about 7 to 8. Neurological symptoms are the result of nerve demyelinization, and the patient may experience loss of position and vibratory sense, ataxia, and spasticity. Other symptoms include a beefy red tongue, secondary to glossitis, and peripheral neuropathy. The liver may be enlarged with pernicious anemia, especially in older adults, indicating they may have a right-sided heart failure. Anemia of chronic disease. That is usually seen in malignancies, renal disease, heart failure, and HIV. Sickle cell anemia, the red blood cells contain an abnormal type of hemoglobin, hemoglobin S, which is sickled, and it's a group of autosomal recessive genetic disorders. Anemia of chronic disease is associated with a low hemoglobin, but it's caused by destruction of red blood cells by a hyperactive reticuloendothelial system, a decreased production of red blood cells by hypoactive bone marrow, or altered metabolism with defective transfer of iron from stores to the plasma. Patients with sickle cell anemia have a normal amount of hemoglobin, so they're normocytic normochromic, but their red blood cells contain the sickled S-shaped hemoglobin. The ultimate goal of treatment for all types of anemia is to provide adequate oxygenation transport to body tissues. For patients with IDA, FOA, and PA, this may be seen as a return to normal in the number and character of red blood cells and normal hemoglobin values. Anemia of chronic disease is normocytic and normochromic, so the goal is to return to the normal number of red blood cells and normal hemoglobin values. Okay, so prevention of iron deficiency anemia includes an adequate intake of an iron-rich diet, monitor in periods of rapid growth, and replacement as needed in infants. Treatment begins with prevention, but iron deficiency cannot be overcome with increased dietary intake alone. Iron supplements are always required. Treatment is based on age and usually dosed about 3 times a day. Monitor their reticulocyte count 5 to 10 days after starting therapy. You'll get a hemoglobin, hematocrit, and ferritin at 4 weeks, and then 3 months, and then annually. And for outcome, we want to see a return to normal hemoglobin, hematocrit, and ferritin levels. Also, if hemoglobin, hematocrit, and ferritin do not return to normal levels, evaluate the patient for a source of blood loss and other pathology. You want to educate your patients on the importance of prevention with adequate dietary intake of iron. Take on an empty stomach, take it at least 3 times a day. It may cause constipation, so they need to drink adequate fluids and take a stool softener as necessary. Folic acid deficiency, risk groups include infant fed goat's milk or powdered milk formula, vegetarian and vegan diets. Pregnancy increases the daily requirement, of course. Patients with sprue, Crohn's disease, Giardia infections, and short bowel syndrome. Also, patients taking drugs that affect folic acid absorption. And that would be phenytoin, oral contraceptives, and methotrexate. Prevention, of course, is adequate dietary intake and folic acid supplementation in pregnancy. Drug therapy is folic acid, 1 to 2 milligrams a day for 4 to 5 weeks. Women of childbearing age and pregnant women should take 0.4 to 0.8 milligrams a day. Assess their hemoglobin and hematocrit in 2 weeks and then regularly. Educate your patient on the need for folic acid, administration, and drugs that may interfere with folic acid metabolism. Pernicious anemia. This defect is caused by a defective secretion of gastric intrinsic factor, which is necessary for vitamin B absorption. It can be caused by a strict vegetarian diet, a partial or total gastrectomy, and small bowel resection. It can be caused by vitamin B12 malabsorption. Prevention includes eating foods high in vitamin B12, such as clams, fortified breakfast cereals, liver, trout, salmon, milk, and eggs. Drug therapy includes oral IM and intranasal B12 replacement. Drug therapy is vitamin B12 therapy. You can give this IM daily for a week, followed by a weekly injection for a month, and then monthly injections as needed. There's oral, nasal, and parenteral formulations that can be given. You will not be responsible for the doses. Reticulocyte counts should be monitored, hemoglobin and hematocrit, iron, folic acid, and vitamin B12, serum levels prior to treatment and at 5 to 7 days of therapy, then frequently until hemoglobin and hematocrit are normal. Monitor potassium level and liver function tests every 2 to 4 weeks to monitor for hepatotoxicity. You should educate your patient on the disease process, the need for lifelong therapy, due to malabsorption, vitamin B12 therapy regimens, adherence to treatment regimens, and monitoring and follow-up. Anemia of chronic disease is the most common form of anemia in older adults and associated with several specific chronic conditions, including osteomyelitis, tuberculosis, rheumatic disease, hepatitis, myelomas, lymphomas, leukemia, carcinomas. Anemia is associated with renal failure occur in secondary to erythropoietin deficiency, and there are guidelines for diagnosing that. Treatment, chronic renal failure or zidovudine treated HIV, they'll get epotin, I'm sorry, in adults and children, and it's usually dosed 3 times a week. Some receive epotin to keep their hemoglobin between 10 and 12. The dosage is increased by 25% if the hemoglobin is less than 10. So these patients go in and get injections weekly until their hemoglobin levels reach 10. Sickle cell anemia, universal newborn screening is done. It's an autosomal recessive genetic disorder. They have that sickled S-shaped hemoglobin. Prevention of sickling is the key to management. Make sure they get their immunizations and they are adequately hydrated. Treatment includes a multivitamin, evaluate for vitamin D deficiency, prophylactic penicillin, usually PIN-VK. Hydroxyurea reduces the frequency of sickle cell pain crisis. These patients are managed by hematology. You may have sickle cell patients that you see, but for sickle cell anemia, they are managed by hematology. They usually have a hemoglobin, hematocrit, reticulocyte, a retic count, platelet count the first year of life, followed by once or twice a year. Blood counts, urinalysis, routine chems annually. The reduction in the number of sickling crises because these patients experience a lot of pain, and we want to prevent organ damage. Okay, let's do a knowledge check. Which of the following patients are at risk for iron deficiency anemia? Would it be pregnant women, an 8-year-old boy, a 1-month-old infant, or a 7-year-old girl? Patient education for the patient with pernicious anemia includes which of the following? Pathophysiology, dosing and schedule for vitamin B12, need for follow-up, or all of the above. Again, that was a brief lecture on anemia. Go to your chapter for further clarification. I briefly went over it. You will be tested on this material. Knowledge check is a good way to check where you are with knowing your information.